Welcome back to the deep dive. Today, we're cutting right to the heart of something really central in medicine, that patient-provider relationship. It's built on trust, vulnerability, but also, well, this constant, tricky moral balancing act.
Absolutely. We're looking at that tension between what a patient gets told and, what information might actually be kept secret.
And this deep dive is all about these huge bioethical issues, truth-telling and confidentiality.
Yeah, and pretty much every dilemma we touch on today, it really comes down to this tug of war between two fundamental ideas.
Okay, so on one side, that's autonomy, right? The patient's right to decide for themselves, to make informed choices about their own body, their life.
Exactly. And pulling the other way is beneficence. That's the provider's duty to do good, to promote the patient's well-being. Historically, though, this often turned into something called paternalism.
Paternalism, like the doctor acting as a parent, thinking they know best.
Precisely. Believing they know what's best for the patient, even if that means, well, managing or withholding information, acting for the patient's own good as they see it.
So our mission today is to kind of unpack this for you. When does telling the absolute truth win out? And conversely, when might that duty to protect others, or maybe even warn them, override that basic promise of keeping secrets?
It's a huge topic. Let's maybe start with truth-telling, because the history here is actually pretty surprising for a lot of people.
Oh, how so?
Well, for a large chunk of Western medical history, there wasn't really a strong ethical or legal duty for doctors to be truthful. You look at the Hippocratic Oath, there's no specific mention of an obligation to disclose everything.
Wow, that's quite something. So for centuries, doctors weren't necessarily expected to be fully honest. What was the thinking there?
The main driver was nonmaleficence first, do no harm. The traditional view was basically that the truth itself could be damaging, harmful, unsettling, and depressing.
So the idea was to manage the information for the patient's therapeutic good, as they called it.
Exactly. The fear was that full disclosure might just cause panic or hopelessness. It could sap the patient's will to live and maybe even make their physical condition worse.
It almost sounds like a kind of therapeutic privilege, almost a permission slip to deceive if you thought it helped. I think I remember reading a quote suggesting the art of medicine involved, what was it, skillfully mixing falsehood and truth.
That's the one. It sounds shocking now, but it was incredibly paternalistic. The core justification was always that if telling the truth kills hope, and hope is crucial for fighting illness, then maybe lying is actually the more compassionate option.
Okay, let's make this real. Let's talk about the case of Karen. This one really gets to the heart of that well-intentioned but potentially devastating deception.
Right. So Karen is 30 years old. She's a mother, has two small children. She comes into the hospital with some really severe symptoms. Her doctor, Dr. Smith, runs tests and diagnoses her with an advanced malignant brain tumor. It's untreatable.
And the prognosis is grim.
Very. Weeks, maybe. And here's the kicker. Karen has repeatedly told people she has this deep, paralyzing fear of cancer.
Oh no, so Dr. Smith is faced with telling this young mother, terrified of cancer, that she has terminal brain cancer.
Exactly. And he decides he can't do it. He can't bring himself to tell her the whole truth. He actively withholds the diagnosis, the prognosis, gives her vague information, maybe focuses on secondary issues, basically deliberately misleads her.
Why? What was his reasoning?
To spare her. To save her from what he saw as inevitable misery and terror in her final weeks. So Karen leaves the hospital feeling relieved, maybe a bit confused, but relieved. She tries to go back to her normal life for about 2 weeks. Then she collapses and dies.
Wow. Wow. So we have to ask, right, was that the right thing to do? Was that deception morally okay? He clearly prioritized beneficence, trying to spare her pain.
He did, but the critics would say he completely stripped Karen of her autonomy. Violently so, some might argue.
Because she couldn't make any informed choices about her own death, essentially.
Right.
If she'd known, she might have wanted hospice care, maybe, instead of trying to keep up a routine.
Precisely. Or maybe she needed to sort out financial things. Or, reconnect with someone distant. Maybe just spend every single moment she could preparing her kids, saying goodbye properly.
She lost a chance to write the end of her own story.
That's a powerful way to put it. And beyond autonomy, there are practical reasons for truthfulness, too. Informed patients, generally, they tend to follow treatment plans better. And on a bigger scale, if people think doctors lie, especially about something like cancer, it breeds massive distrust. We saw that historically.
Yeah, you mentioned the history. You could really see that shift in the actual data, can't you?
Oh, dramatically. There was a study in 1961, I think, where something like 90% of physicians admitted they usually didn't tell patients patients they had cancer.
90%.
90% avoided it. Fast forward less than 20 years to 1979, same question. Now, 97% of physicians said they would disclose a cancer diagnosis.
That's an incredible turnaround, like a complete ethical flip in less than a generation.
It really shows how much the value placed on patient autonomy and their desire for information has grown. It's become central. Though it's worth adding, the data still suggests some doctors might be hesitant about revealing the full prognosis, the how long have I got part, even when they do reveal the diagnosis itself.
Okay, but what about the argument that medicine is just too complicated? The skeptic who says, how can you tell the whole truth? The patient won't understand the nuances of oncology anyway.
That's a fair question, but I think it kind of misses the point. The duty isn't necessarily to convey every single technical detail like giving a medical lecture. You don't need a PhD to make a decision about your own health.
So it's not about the complete truth in that sense.
No, it's about being honest and conveying the essential and relevant information. Enough for the patient to grasp the nature and the seriousness of what's going on. Enough to make an informed choice.
Right. Like if you take your car to a mechanic, you don't need the full engineering schematic. You just need to understand what's wrong, what the options are, and what the implications are to decide whether to fix it.
Exactly. It's about achieving adequate understanding for decision-making.
Okay. That makes sense. And that idea of necessary information, it leads us pretty naturally into the second big area, doesn't it? Confidentiality.
It does, so confidentiality. Basically, the provider's promise not to share private health information. This one is ancient. It's right there in the Hippocratic Oath.
And it's related to the right to privacy, right? Which is more about the patient's authority to control who gets access to information about them in the first place.
Correct. They're intertwined. So why is the secrecy considered so vital? The arguments tend to fall into two main camps.
Okay, what are they?
Well, first, there's the consequentialist argument, looking at the practical outcomes. Meaning, if patients fear their doctor will blab, they won't share sensitive, maybe embarrassing, but crucial information needed for a proper diagnosis or effective treatment. Trust breaks down. Plus, if confidentiality is breached, it can lead to real harm, job discrimination, loss of insurance, social stigma, ruined relationships.
Okay, makes sense. Consequences. What's the other camp?
That's the nonconsequentialist view. This one's rooted more in fundamental duties and rights.
Like autonomy again?
Exactly. It argues that confidentiality respects the patient's basic right to control their private life, their personal information. It respects their autonomy. And crucially, it also honors the doctor's implicit promise, their duty of fidelity, to keep secrets shared in that trusted space.
So, given how important it seems from both angles, is this duty of confidentiality absolute? Like, can it never be broken? Or is it what ethicists call prima facie?
Good question. Prima facie means it's binding, unless it conflicts with an equal or stronger duty.
Okay. So, which is it generally considered?
Well, in the real world, especially in law, it's treated as prima facie. Medical information is privileged, yes, but most places have laws that require doctors to breach confidentiality in specific situations.
Like what?
Things like reporting certain contagious diseases to public health authorities, reporting gunshot wounds, or suspected child abuse. The idea is that the protective privilege, as the courts call it, has limits. It ends when there's a significant risk to the public.
The public peril begins where the privilege ends,
Right.
or something like that.
That's the famous line, essentially. And that brings us right to the really sharp end of this debate, the duty to warn. When does confidentiality have to give way to protecting a specific person from harm?
And this is where that landmark case comes in, isn't it?
Tarasoff.
Yeah.
Tarasoff v. Regents of the University of California, yes. It's probably one of the most cited cases in all of bioethics and mental health law.
Remind us of the basic facts again. It's quite a story.
It is. So back in 1969, a university student named Prasenjit Poddar was seeing a psychotherapist at the campus health service. During therapy, Poddar explicitly stated his intention to kill another student, Tatiana Tarasoff.
He told his therapist he was going to kill her.
Clearly. The therapist was alarmed, understandably. He contacted the campus police, recommending Poddar be detained for observation. The police did pick him up, but they assessed him, decided he seemed rational enough, maybe got assurances from him, and let him go. Crucially, neither Tatiana nor her parents were warned about the specific threat.
And Poddar.
Poddar later befriended Tatiana's brother to get close to her, and then, tragically, he carried out his threat. He murdered her.
Unbelievable. So Tatiana's parents sued the university, the therapist, the police.
They sued, arguing that the therapist had a duty not just to try and get Potter detained, but to actually warn Tatiana directly or someone who could protect her, like her
Then
parents.
court.
The California Supreme Court, in its final 1976 ruling, agreed. They established this principle. When a therapist determines, or should determine, that their patient presents a serious danger of violence to another specific person, they have a duty to use reasonable care to protect the intended victim. That might involve warning them, warning others, notifying police, whatever is necessary.
So the protective privilege ends where the public peril begins. That ruling basically created a legal duty to breach confidentiality in specific, dangerous situations.
It did. But it immediately created this huge ethical tension, didn't it? You raised it earlier. If therapists have to break confidentiality, won't that scare potentially dangerous people away from seeking help in the first place?
Exactly. It seems like a catch-22. You try to prevent one harm by warning, but you might create a bigger hidden harm by discouraging treatment altogether.
It's a genuine paradox. The court ultimately decided the immediate threat to a specific life outweighed the potential, more diffuse risk of deterring others from therapy. But it absolutely complicates the trust that's so essential for mental health care.
And this isn't just theoretical, right? This tension plays out all the time. Think about that case file example, Carlos R.
Right. Carlos R., an uninsured patient. He's HIV positive. He lives with his sister, Consuela, who has agreed to be his caregiver at home, changing dressings, helping with personal care, that sort of thing.
Okay.
But Carlos absolutely refuses to tell Consuela he's HIV positive. He forbids the healthcare team from telling her.
Oh, wow. That is a messy situation. So what are the arguments there?
Well, on one side, you have those defending Carlos's confidentiality. They might argue the risk to Consuela isn't necessarily imminent in the same way Potter's threat was. They'd say, look, just train Consuela really well in universal precautions, gloves, hand washing, safe handling of sharps. Manage the risk without breaching confidence and potentially destroying Carlos's family support system.
Okay, that's one perspective. Protect confidentiality, manage the risk.
But the other side argues really strongly that Consuela has an absolute right to know what she's dealing with. It's her home, her health. She needs that information to give truly informed consent to being his caregiver and to protect herself properly. They might even argue the healthcare system is kind of using Consuela's ignorance to get free care for Carlos, care that would otherwise require paid professionals.
So they're saying her right to know, her autonomy in managing her own risk, potentially outweighs his right to confidentiality in this specific caregiving context.
That's the core of the conflict. Can you protect his privacy and her right to make informed choices about her own safety and involvement? It's incredibly difficult.
And all of this is happening against a backdrop where confidentiality in general might be harder to maintain anyway.
Yeah.
You mentioned Mark Siegler's argument.
Right. Siegler wrote quite provocatively that the traditional ideal of doctor-patient confidentiality is basically, well, he called it decrepit,
Yeah.
a relic of a bygone era.
Why? Because of computers and bureaucracy.
Essentially, yes. Think about modern healthcare. It's not just one doctor and one patient anymore. You've got electronic health records, teams of specialists, nurses, technicians, pharmacists, billing clerks, insurance auditors, maybe students. Siegler estimated that anywhere from 25 to maybe 100 different people could legitimately access a single patient's hospital record.
100 people.
Yeah.
Yeah.
And each access point, even if legitimate and necessary for care or administration, is another potential point of, well, indiscretion or accidental disclosure. Even with privacy rules like IPA, the sheer number of people involved makes absolute secrecy incredibly hard to guarantee. The system itself kind of erodes it.
So we've got these deep conflicts, truth versus potential harm, confidentiality versus duty to warn. How do different ethical frameworks help us navigate this? Because they don't all lead to the same answers, do they?
Not at all. Different moral theories provide different lenses, different ways to prioritize these competing values. Take Kantian ethics, for example.
Okay, Kant, what's his approach?
For Kant, it's all about universal duties and respecting persons. His categorical imperative, especially the part about never treating people merely as a means to an end, demands absolute rules.
Absolute, meaning no exceptions.
Pretty much. Lying to a patient, even for their own good, like Dr. Smith did with Karen, uses them as a means to an end, sparing feelings, and violates the absolute duty to tell the truth. Similarly, breaking a promise, like breaching confidentiality, is fundamentally wrong because it violates respect for the person and their autonomy.
So under a strict Kantian view, Dr. Smith had to tell Karen the truth, no matter how painful. And the Tarasoff therapist could never have warned Tatiana, even knowing Potter's threat.
That's the logical conclusion of a purely Kantian approach. The rule is paramount, regardless of the consequences.
Okay, that's pretty rigid. What's the opposite end of the spectrum?
That would probably be act utilitarianism.
Utilitarian, that's about maximizing happiness, right? The greatest good for the greatest number.
Exactly. But act utilitarianism says you judge each specific action, case by case, based on its likely consequences. There are no absolute rules like never lie or never break confidence.
So the physician has to kind of calculate.
Yes, they'd have to weigh the potential happiness and unhappiness for everyone affected by the decision. Lying versus telling the truth.
Hmm.
Maintaining confidentiality versus breaching it. Which specific act in this specific situation will produce the best overall outcome?
So for Karen, the act utilitarian might say lying was justified if sparing her 2 weeks of terror genuinely created more overall well-being than telling the truth would have.
Possibly yes, if that calculation worked out. And conversely, the Tarasoff therapist would likely be obligated to breach confidentiality because saving Tatiana's life would almost certainly maximize overall good compared to letting Potter carry out his plan.
Okay, so Kant gives us absolute rules. Act utilitarianism gives us case-by-case calculations. Is there anything in between?
Yes, that's where rule utilitarianism comes in. It tries to bridge that gap.
How does that work?
Rule utilitarians agree the goal is maximizing overall good, but they think the best way to do that is by following general rules that are proven to produce the best consequences if generally followed by everyone.
So instead of calculating each act, you follow rules that usually lead to good outcomes.
Right. So a rule utilitarian might support a general rule like always tell patients the truth or maintain strict confidentiality. Because in general, following those rules leads to more trust and better outcomes overall than general rules permitting lying or breaching confidence.
But what about exceptions, like Tarasoff?
That's the key. A rule utilitarian framework can build in exceptions to the general rules if having that exception itself produces better consequences overall. So you might have a rule like, maintain confidentiality except when necessary to prevent serious, imminent harm to an identifiable third party. The rule itself contains the justified exception.
Okay, that sounds a bit more practical, maybe. And there's one more approach you mentioned, virtue ethics.
Right. Virtue ethics shifts the focus entirely. It's less about rules or consequences of specific actions and more about the character of the moral agent in this case, the physician.
So it asks, what would a good doctor do?
Essentially, yes. What kind of person should the physician strive to be? The goal is cultivating virtues, character traits like honesty, fidelity, loyalty, faithfulness, compassion, justice, courage.
How does that apply to, say, truth-telling?
Well, a virtuous physician would embody honesty, so they would be truthful, but they would also possess compassion. So how they tell the truth would matter immensely. They wouldn't just bluntly state facts. They would deliver the truth sensitively, tailored to the patient's ability to cope, considering their emotional state. It's about wise and compassionate application of honesty, not just blind adherence to a rule.
So it's about the physician's judgment and character in action.
Precisely. Finding the right way to be truthful and trustworthy in each complex human situation.
Okay, we've really covered a lot of ground here. We started with that fundamental clash in truth-telling, the old paternalism, versus the modern emphasis on patient autonomy, leading to this general agreement that patients have a right to the essential truth, even if it's hard news.
Right. And then we unpacked confidentiality. We saw why it's so crucial for trust, but also why it's generally seen as a prima facie duty, one that has to yield legally and ethically in specific situations where there's a serious, foreseeable danger to others. That duty to warn.
As we wrap up, there's one more layer we really need to touch on, something that complicates all these theories we've discussed, and that's cultural context.
Ah, yes. That's hugely important. Most of the frameworks we discuss, historically, they've emerged from a Western, particularly European-American cultural background. And that background tends to place a massive emphasis on individual autonomy as the supreme value.
You mean assuming everyone everywhere prioritizes individual choice above all else?
Kind of, yeah. But the sources we looked at point out that this isn't universal. Many other cultures the text mentions, examples like some Mexican-American or Korean-American communities might place a much higher value on the family, the community, the social network.
So decisions aren't purely individual.
Not always. In some cultural contexts, there might be an expectation that the family plays a central role in receiving information and making decisions, sometimes even shielding the patient from distressing news. What looks like truth-telling from a purely individualistic Western perspective might be seen as unnecessarily cruel or disrespectful if it strips a patient of hope. especially if done without consulting the family unit that's providing care and support.
That really adds another layer of complexity for doctors, doesn't it? When you're dealing with diverse patient populations, whose autonomy are you primarily serving? The individual who might actually prefer the family to handle things, or the family unit itself.
It's a profound challenge. It forces us to move beyond applying ethical principles rigidly and instead focus on understanding the patient's values, their family's values, and finding a truly respectful and compassionate path forward in their specific cultural context.
It really underscores that ethics in practice has to be sensitive, adaptable, and deeply human.
Couldn't agree more.
Well, we hope this discussion has given you a solid grasp of these critical, often difficult debates in bioethics. Thanks so much for joining us for this deep dive. We'll see you next time.